is Dr. Ross Crawford. He's from Australia. He's a robotic knee and a hip surgeon. For me, I'm Dr. Manoj Wadhwa. I'm heading Max Hospital, Mohali, and I'm the course director for this Elite Arthroplasty Congress. On my right is Dr. Jeffrey Jeller. He's from New York, USA, and Dr. Jeller is going to be performing the first robotic live surgery beaming from Max Mohali into this JW Marriot tomorrow morning. And the system we're going to be displaying tomorrow, the implant is also the launch for the first time in the country. It's called as the Journey to Uni. Uni means that you're not replacing the entire surface of the knee joint, you're only relining one particular part of that, one particular compartment of that.
So the ligament will be intact?
Ligaments and structures will be intact. So Jeffrey, why don't you add up on this thing?
Sure. A partial knee replacement typically aims to replace only, in about 85-90% of people, the inner half of the knee, which is in the vast majority of people, that's the part of the knee that wears out first. So in the earlier stages of disease, what we hope is to catch it early, replace the inside half of the knee, and then really stop the arthritic process from progressing. But the benefits of a partial knee are a smaller surgery, a faster recovery, and maintaining more of the patient's own natural anatomy in order to get them back to a hopefully more normal feeling knee.
So how sooner or later the patient can get back after this surgery?
Well, it depends on the person. It depends really on how quickly somebody recovers, but generally in the United States where I do this, many times I'm sending patients home the same day. They don't even stay in the hospital.
Going back home the same day.
Same day or one night.
Small cut.
It's small
Yes, yeah, minimally invasive.
So it's very precise actually. You have to, microscopically visualize the kind of defect or maybe the ailment it has.
It's between X-ray, physical exam is when, the art of a partial knee replacement is in whether or not the patient is an ideal person for the surgery. So if the arthritis is a little too advanced, then they're not a good candidate for it. But if you catch it at the right time, they can be.
This is an important point we're saying, that this partial knee is not for everybody. You have to choose the right patient. The right indication is very, very important. Not that people start thinking, I have a skewed up, totally bowed up legs, and this is one choice for me.
So it needs a lot of homework from your side actually, maybe.
It's a little bit of homework, yes.
Yeah.
A lot of, because you have to, make the patient free on the same day. It makes a lot of, impact on you. It's like pressurize you a lot actually, because like your complete study would always, fetch the good results.
Yeah, well, it really starts with the patient, and we know almost at the time they come to see us whether or not they're a good candidate for a partial knee replacement. Meaning if a lot more of the knee is worn out, if the arthritic process has progressed a little too far, then we know those patients, even if the surgery is done perfectly, those surgeries will not have a good result because they have arthritis in other parts of the knee.
So, what is the success ratio? I mean, you're saying that it may be like not 100% successful all the time.
For the right person, the right candidate, we're in the 98-99%. If they get well. If it's not the right.
In cases, like what do they do?
I'm sorry?
The 2% failures. So maybe not the failures actually, for the not complete healing.
Well, there may be scenarios of infection, fractures, or some continued pain in the knee.
So does it involve you only to do this kind of surgery, or is it required a lot of other practitioners?
No, it's typically me with a variety of assistants.
So you can explain on this particular.
Maybe if you have a total knee to compare.
So So we'll need a total knee implant.
To bring a total knee to compare.
So how long does it take the surgery?
Approximately an hour.
Approximately.
Yeah.
So, and the sutures, what kind of sutures do you do after, the small cuts? Do they need sutures also, the Marceline suture?
Yeah, usually it's similar sutures to a full knee replacement, but just fewer, smaller.
The smaller one? Yeah. Do they get dissolved inside itself?
It depends on the surgeon preference. There's a variety of different ones. People close knees all differently.
Do you remember, it's not microscopic, it's it's 6 to 8 centimeters. It's still a cut.
Yeah.
It's still visible,
Sure,
and it's still.
Sutures are always visible. So basically, it's not a so small cut. But
So
it's
this
like
will explain what. So this is a conventional normal total knee, and that one is a partial knee.
So if we compare the two of them together,
This is original implant,
these are real implants.
real implant. This is what is a total knee. This is what is we are talking of. This
So
is
you might imagine it's just this segment of the full knee replacement is all we're doing. So it's only essentially 1/3 of the knee.
of course, there's a
much
lot of
lighter.
difference.
we leave it in place.
Yep.
That's the new knee.
That's the new.
Significant.
Yeah, that's the new knee.
Yeah, that's it. See the difference.
Would you like to add something to it?
My thoughts are very much the same. What we're doing is taking a smaller operation that we can now do more precisely, and the robotic technology, as it's evolving, is going to allow us to get it
Someday it will be on the mobile itself that you're driving home and you're just doing the surgery itself.
just about like a driverless car. This is the beginning of a revolution in healthcare, where
Exactly.
robotic healthcare is going to start to.
So high-speed
really-
machines are replacing the slow machines, and then probably the surgeries are also.
Yeah, I think surgeons are pretty safe. There's a lot of cutting and
Exactly.
balancing.
You know
and-
where it need to be done.
Yeah.
Actually, how
Yeah.
it's gonna help, and the quantity actually.
Yeah.
The quantity of the suture, the quantity of cuts, the quantity of the measurements.
Yeah, so that's going to, and we're still planning it and deciding it, and like an architect designs a house and then a builder might do it and use good equipment, good machines, we'll be the architects who'll
Soon.
design and we'll do a lot of it, but this will just make us better. And if it makes good surgeons better and training surgeons better, then it's going to be good for patients.
Good for patients.
And that will save some of the upfront costs in the start. If you can do less reoperations, patients get back to work quicker, and then they're a very, sometimes you have to spend money up front to save money. It's like building a new road that allows, it costs money up front, but it actually allows increased productivity. And so going home earlier, getting to work quicker, functioning better, being able to do a lot more, will have long-term economic benefits for somewhere like India.
Do we have all the equipment here in India itself? Do we have all the facilities which are required for this particular, or is it like one only Max, or any other hospital does have?
No one in India has actually bought one yet. It's really only been, these sorts of systems are really just starting to be rolled out around the world.
Right.
And but I have no doubt within 6 or 12 months that India will, and technology is a very big driver for the Indian future, and I think it'll be a big part of Indian orthopedics.
So Indians are the best doctors, I probably vouch on that.
You could say they're very good surgeons.
Today he's a guest, so he's bound to say so.
They're very good surgeons, and if you look at the US, who runs all the IT? It's the
80%
Indians.
in US are.
Indians are fantastic at this sort of gear.
So what's your take on that, Geoffrey? We are on that actually. I mean, how this surgery, you're doing it for once, and would others follow this particular thing?
Yeah, I mean, it requires a lot of resources. It requires a lot of training and concentration. But yeah, I think that if a hospital and doctors take that step into securing the technology, it does. It allows them to do a lot more than they've perhaps done in the past.
You can continue.
Shimon?
I do use them quite often for some reason. I think it's probably a study to be done, but in my practice I find that if I want to get a proper coverage on the tibial or on the femoral side, I do need to have offset rods quite often.
I use it very frequently, and it just helps you get that fixation in the shaft, plus good coverage and knowing, because if you've got that, particularly in the tibia, if you've got it overhanging on the side, you can get impingement, and that's very uncomfortable for the patient. And on the femoral side, I use it particularly to improve the flexion and extension gap. And you can either increase the size of the prosthesis or offset it more, and it just makes it
That much
fine-tune-
more perfectly aligned on the...
fine-tune the procedure so much better.
Talking about fine tuning, I want to
Regarding the offset, suppose if there is a malunited femur, it's a metaphyseal malunity.
Sure.
That's another indication I just want to add along.
Sure. One of the commonest indications for using offset is in post-HTO knees. In India, we still have a residual, critical population with post-HTO deformities, and that's where these offset stems can be very useful. So coming to the fine-tuning, there are offset stems and then there are offset stems. For example, Smith and Nephew has got the dialing facility to give that offset, and I personally feel that's a fantastic thing because it gives you the ability to locate your tibial tray in a 360-degree manner instead of a fixed offset of 2 millimeter lateral or medial. So
yeah, I think I have used those stems, and as you rightly said, they are wonderful for the tibia. So I would use the offset stem quite often in tibia, but rarely in the femur.
So the message for the audience is that when you familiarize yourself with the options on the market as far as this offset facility is concerned, and quite often you might find that in offset can be very useful.
Okay, I think we'll press on because last 10 minutes and I want to use those 10 minutes for...
I just wanted to make a quick comment.
Yes.
A long time ago I was teaching and the instructor asked us to teach offset, and I'd say 35% of my practice is revisions, and I said to him I've never used an offset. I trained with Lombardi, and at that time there was no offsets. So Joe Nestler was at the table beside us from Mayo. I said, Joe, can you show this group of students how to use an offset? And he said, I've never used one. I think it's just whatever you're more comfortable with.
Okay. Sure.
But on the femoral side, I'll just upsize or downsize and augment.
So what the message he's giving us is that there are ways to get around a situation where an offset stem is one way of addressing an anterior-posterior movement of your femoral component or a medial-lateral movement of your tibial component. But then there are other